Does the child exhibit a significant number of behavioral symptoms of ADHD? We're going to compare what's been reported to our symptom checklists. We're going to look at age and gender norms. Are those behaviors occurring significantly more frequently than children of the same gender and age? At what age did these begin? Okay. They should have begun before age 7 if we're going to use the DSM criteria. People have begun to kind of oftentimes ignore that one a little bit. People are fudging on that a bit. You have to use professional judgment, but most typically, the kids with the most significant symptoms typically do appear before age 7. Kids with milder symptoms may not show up as well. The question is about gender-based norms. The DSM doesn't really say anything about gender differences. The literature suggests that girls tend to present more with the inattention symptoms, a little less with the hyperactivity and impulsivity symptoms. So we want to keep that in mind. But so that's where professional judgment is going to come into play. It's also the case that girls may present, there's a little higher prevalence rate of girls with the primarily inattentive type, which goes along with that idea as compared to the combined type. So we might be a little less conservative with girls, but it will depend on the other kinds of issues that they are presenting with, I think. I think the tools that do have gender norms are going to be most helpful there, gender and age norms, in kind of getting a relative sense of how does this young girl compare to others. And then I think the issue of severity and chronicity of presenting symptoms is also going to be helpful. And I think the bottom line is, are we going to provide support and intervention services? And we're probably going to do that on a wide range of presenting symptoms, from mild to moderate to severe. Then the second question, or another question, is, are we going to suggest making a diagnosis? And I think what we see more boys being diagnosed than girls. And I think what we're more likely to see is, we might say that girls are presenting with attentional problems, but we might not make the diagnosis. Ultimately, we have to make a judgment. I mean, this is where we get into parse. It's like we're going to parse things. How accurate and how completely accurate can we be? And it's kind of like, it's not going to be a black and white, perfectly clear set of issues. In most cases, there's going to be some confusion for us. So we're going to make our best judgment. And I think it's also the case that we have to be willing to revisit this issue over time. Okay? I mentioned to you, well, I may not have mentioned to you, but in working with younger children, I like to talk with parents about, your child meets these criteria, and I would say that they're at risk for developing ADHD. And that's for children ages 3 through about age 6 or 7. Okay, I think it's fudging a little bit, but in some sense it's being conservative. In terms of ages 7 to about 12, I think you can say your child meets these criteria or does not, and can legitimately be identified as a child who's identified with ADHD or diagnosed with ADHD or not. And we still need to be concerned about, if not, we still need to be concerned about what kinds of problems is she or he presenting with. Okay. So we want to ask, what age did these begin, and are they evident across many situations? The across many situations is critical, okay? And it's at least 2 settings for making this diagnosis. So it can't be school-based only, and it can't be home-based or community-based only. And is the child's functioning significantly impaired? Okay? And are there other possible problems that could account for symptoms, as I was mentioning? So family circumstances, parental dysfunction or parental problems in terms of management, learning problems, and so on. So another way to say all those things is to say, what's the number of ADHD symptoms? Do we meet the criteria? 6 of 9 in each one. Okay. Deviance from age and gender norms, age of onset, chronicity, pervasiveness, degree of functional impairment, and ruling out alternative hypotheses or problems. Okay? So if we do that, we've avoided confirmatory bias. That's the big issue here in diagnostic evaluations. Okay? We want to rule in and rule out alternative explanations as best we can. Okay? All right. We've talked a little bit about these things, alternative hypotheses for ADHD behaviors. So environmental factors can be things like antecedent or consequent events. I talked about, being with one parent or another, or being in one particular environment, an environment that's not very clear in terms of what the expectations are. Placement in the curriculum. Is the child placed in material that's too difficult or too easy? I had another student do a dissertation on that topic relating to the whole idea of curriculum-based measurement and survey-level assessments. But if you think about curriculum-based measurement and you think about children being taught in material that's of an instructional level, so if you would say to teachers, let's say we want to get 50 teachers and 1,000 kids, 20 kids in each of those teachers' classrooms, okay? And we want to say to the teachers, go down this list and tell me which of the kids are placed in instructional level material for reading. These are second and third grade students. Okay? And which kids are placed in material that's too easy for them, they could be moved up. And which kids are placed in material that's too hard for them, they should be moved down in material. So what do you think the teachers said? About 95% of the kids were appropriately placed. What do you think the data said on the assessment? About 78% of the kids were appropriately placed. Okay. What does that mean for ADHD-related diagnostic evaluation? It means you have to do an academic assessment and you have to look at, is the child able to do the material, able to work with the material that she or he is being presented with? Is it too difficult is one question we have to rule out. And second, is it too easy? Not challenging enough. We have to answer that question. Is the child appropriately placed in instructional level material? Okay, and then psychosocial stressors. Okay, is the child living, the parents getting divorced is an easy example, or parents or other kinds of difficult circumstances. So if the answer is the child's not placed well in the curriculum, the child is living in a family experiencing psychosocial stressors, the child is in a classroom where there's not good classroom behavior management, we're going to say what? The child meets the criteria for ADHD or is presenting with all of these symptoms, but it's not appropriate at this point in time to make a diagnosis of ADHD, because an alternative explanation at this time is that the behavior management in the classroom is not working well, and many children are presenting with similar types of behaviors. So we want to put, our first action would be to support the teacher. You can't wait to do this, right? All right. Well, we can do it. We're good communicators. We can talk about, if we can't talk about this, the alternative is we're going to say the kid has ADHD. We're not going to do that, okay? So we're loath to do that. Or the child's family circumstances are difficult. So the first thing we're going to do is try to stabilize that, and then we're going to revisit this. Eventually we might make this diagnosis. But from a diagnostic point of view, these are the things, this is the way we want to approach it. Now, my good fortune is that I'm a university professor, so I get to live in this wonderful world, okay? So I get to tell you, this is how you should do it, okay? And then, but I've worked in schools, and I do work in schools all the time. I work with the State Department of Education. I work with my students. We have some embedded projects focusing on school psychology in a middle school and elementary school. So I know the realities too. So these are not easy things to do. I know that. But it's a day for professional development. So we're going to live in the ideal world, and then you're going to mediate that with your real world when you go back. But So within child factors, if we have academic skills deficits that we think are primary, we're going to first intervene there and see if the attentional problems abate. Okay? So we want to try to do that. And then we might have we think that anxiety is the main problem. So we want to do some kind of address anxiety problems first and then see what happens with the attentional problems. So if we have alternative explanations for the presenting symptoms, we're going to try to do something that's going to help us think about, do the attentional problems abate as a function of addressing this alternative explanation? Okay? Or we might decide that it's appropriate to say the child has academic skills difficulties and ADHD. So an example of that would be the child first started presenting with attentional problems at age 2.5. Okay, and was difficult to manage and colicky from birth, and presented was one of my projects when I worked at the University of Oregon. I worked with 3- and 4-year-old students who were essentially expelled from preschool, but they called it discontinued. Their enrollment was, they called it discontinuation. In any case, these were children who were difficult to manage at age 3 and 4, and we had a parent behavior management project and a medication evaluation project. But in essence, there are children who present with very difficult to manage behavior at early ages. And by definition, to meet the criteria for ADHD, they're going to be presenting by age 7. So my point is what? That if they're presenting with academic skills deficits, along with attentional symptoms and impulsivity symptoms, we may still make the diagnosis of ADHD in any of these circumstances and say that a treatment plan should incorporate the features that will address not only ADHD-related behaviors, but the other symptoms or other issues that are happening in that student's life. That's a professional judgment decision that we have to make. Okay? So, and the distinction there is, do we believe as a professional that the issues relating to academics are primary and the attentional problems are secondary to that? If that's the case, it's likely that there's not as many problems at home as we see at the school. Okay? If family circumstances are difficult, that might create pervasive problems and make it difficult for us. But if we have, if we think the whole class behavior management is a problem, that will be probably guided by, we see this problem in this classroom, but we don't see it in other situations. Okay, so that's where our differential consideration of different circumstances is going to come into play. Okay, so we're going to try to rule out these different disorders, and so just real quickly, in the few minutes that we have left, with anxiety problems. So I want to talk a little bit, and you have these slides, I believe, in your handout. But with anxiety problems, kids with ADHD are not really concerned about their competence. As I said, they're very confident in their competence. Kids with anxiety problems are always asking about their competence. How am I doing? Did I do that right? Can we play together? Will you be my friend? Those kinds of things. Kids with ADHD exhibit little or no fear. That can be a problem in terms of getting into accidents. But kids with anxiety problems tend to be the opposite of that. Kids with ADHD have no difficulty separating. Kids with anxiousness tend to have that. So these are some guiding things that you're going to want to think about in distinguishing between ADHD and anxiety problems. Remember, kids with anxiety problems present as attentionally challenged, if you will. And so we want to think about what's the comparison. How will we think that through? Okay. Kids with depression versus ADHD, if you will, have experienced, or there should be some history there of a marked change in affect or mood. So they were doing really well, and they weren't having these these types of attentional problems, but there was a change at some point in time, and all of a sudden they've started to have attentional problems. This is a place where we get into that they should have lasted for 6 months, and they started at a certain point or before age 7. That can help us there. But with depression, concentration problems tend to have more of an acute onset and might follow a stress event. So we're going to want to interview for those kinds of things. And we see changes in eating and sleeping habits with depression. We're not necessarily so with ADHD, and a loss of interest or pleasure in activities. So you know the symptoms of depression, and we're going to want to try to rule those out, if you will, if we're concerned. But this is one of the issues that we want to think about, and think about internalizing problems, anxiety and depression relative to ADHD. In terms of oppositional problems and conduct disorder, as I mentioned earlier, with conduct problems, you tend not to see the impulsive and disinhibited behavior. Okay, and you tend to see that children are able to complete tasks, but they resist initiating, responding to tasks that they're asked to do. So you see that oppositionalness. Do this, I want you to do this work, and they throw their book on the floor, or I want you to do this, and they immediately say, no, I'm not doing that, or worse than that. But kids with ADHD are not necessarily that type of non-compliant. Okay. They will most likely want to be pleasing teachers and parents, but they have a difficult time doing so. Okay, so we want to think about that. Children with ADHD have poor sustained attention and marked restlessness. Kids with ODD and conduct disorder you tend not to see that. They're able to pay attention. They tend not to be so restless. And again, you want to look real carefully with respect to parent functioning and parent management practices with respect to comparing ODD and CD relative to ADHD. And then with learning disabilities and ADHD, we get into this, again, this is a chicken and egg problem. So this is really hard to do. Okay, but if attention-related problems arise in middle childhood or tend to be task or subject specific, that might tell us it's more related to a learning problem as compared to ADHD. If there's no early childhood history of hyperactivity, that might be more of a learning problem. And if you see a lack of impulsive or disinhibited behavior, but real difficulty with academics, that might more likely be a learning problem. Okay. So the last part of my presentation, which I'm not going to get to, has to do with intervention planning. And these are the things we're going to want to think about. We're going to want to think about how severe are the problems. Okay, so how challenging is it to support this student in the environments that I'm thinking of providing support. And that severity is kind of, again, reference to normative behavior. So, and we're asking the question really there, how different is this child behaviorally relative to the others, and what am I asking a teacher or a teacher and a teacher aide to be able to do relative to helping to support this student in this classroom? What functions might some of the problems serve that the child is presenting with? Are there associated problems or disorders? How has the child responded to previous interventions? What kind of resources do I have? And I want to ask about contextual fit. I mean, we can design interventions. Contextual fit, if you go to the PBIS website, Positive Behavior and Intervention Support, they have a tool called the Assessment of Contextual Fit rating form. And it asks teachers or parents, you can adopt it for parents, to rate to what extent has the person asking me to implement this intervention taught me about it. That would be contrasted with I left a piece of paper in their mailbox. We don't want to do that. But did they teach me about it? Do I have the skills and knowledge to actually do it? So we talk a lot about behavior management. There are a lot of teachers that haven't had much in the way of training in behavior management. So it's good to make sure you help them understand what it is you're asking to do if you're asking them to implement a behavior management plan. I have the resources, I have the time, it fits with my beliefs about children and behavior, all of these questions. If we don't have good contextual fit, then we're not going to have good implementation, and then we're going to have what I used to call, when I worked in schools for a lot of my time, the bane of my existence was I tried that and it didn't work. And the reality was, they didn't really try it, but what do I say to that? So that was even more challenging than your whole class is a problem. So Anyway, assessing contextual fit in a proactive way and responding to that can be helpful in terms of intervention planning. In summary, I want you to think about those main issues. You want to avoid confirmatory bias. You want to if you're doing diagnostic work, you want it to be multi-informant, multi-assessment tool, multi-method, and multi-setting. Okay? You want to remember that there's diagnostic homogeneity, so all of these kids are different. And you want to think about the assessment process as answering and addressing different types of questions: screening, diagnosis, intervention planning, and then the whole issue of ruling in and ruling out alternative hypotheses is critical to the whole endeavor.